join me on this week's video. On this week's video, we're going to be discussing the pain-related impairment. Pain-related impairment. And I want you to know that today's material comes as a direct response to one of my subscribers' requests for additional elaboration as to how to properly provide for additional permanent impairment due to the added burden of pain on the impairing condition, or due to the excess pain that the examinee may be experiencing associated with some permanent impairment. And I want you to know that during the course of a normal week, I receive many phone calls and emails from QME evaluators of all specialties throughout the entire state of California. And I'm accumulating a growing list of common questions, concerns, and issues that today's qualified medical evaluator is facing. And I'm going to be creating a new series of video blogs for you over the next several weeks and months to address the most common concerns and questions that I'm getting. And we're beginning today with one of those, which is the pain-related impairment. So I'm excited to be bringing to you the next several video blogs, which are intended to provide immediate benefit to you and in your QME practice. So when you receive my video blogs over the next several weeks, make sure to open those and to view those videos. They're going to be discussing questions that could very well easily have come from you, except that you did not pose it as a question, whereas someone else did. And I can imagine that if one qualified medical evaluator has a question or concern in an area, it's possible that many others have the same question or concern. They just don't know it yet, or haven't yet posed the question, or haven't yet sought additional information regarding that topic. So I'm going to be bringing you what are the answers to the most common questions and concerns that are facing today's qualified medical evaluators. So make sure to open those video blogs when you get those. You're going to find the topics and the discussions to be fascinating and immediately beneficial to you in your QME practice. I'm also excited in another area too, and I want to extend an invitation to you. And I want to let you know that on January 27, 2015, I will be speaking for the California Chiropractic Association at Squaw Valley, and I'll be speaking for 6 hours on QME recertification. And if you need QME continuing education hours, I want to invite you to attend that presentation. And this video is being recorded on April 15, 2015, and I'm already preparing my topics for the January 27 presentation for the California Chiropractic Association. And I want to let you know that the topics that I plan on presenting to that audience are going to be the most current, the most relevant, and the most pertinent issues facing today's qualified medical evaluator. And in the time between now and June 27th, I'm going to be attending several additional continuing education QME courses given by other vendors. So I'm going to be accumulating the very latest information and the very latest knowledge in our industry, and I plan on presenting the very best and the most relevant topics to you on January 27th at Squaw Creek. So I encourage you and I invite you to attend that presentation. If you do attend that presentation, I want you to make it a point to come up and introduce yourself to me. I look forward to shaking your hand and getting to know you and talking about all issues QME. So please accept my invitation to attend. And over the next several video blogs, I'll be revealing to you a glimpse of some of the topics that I plan on discussing on June 27th. Now, if you want to register for that seminar, simply go to www.calchiro.org and look for the right in your backyard seminars, and you'll see clearly listed the very next seminar at Squaw Creek on June 27 and 28th. So I would look forward to meeting you at that presentation, and I hope to see you there. Okay? Now, with those administrative issues handled, I want to get into the topic of today's material, and that has to do with the pain-related impairment. So we're going to be discussing many concepts out of Chapter 18 today. And our overriding theme for today's presentation is, how do I properly provide for additional permanent impairment due to pain? Due to pain. That's the critical question. And the reason we raise this question is because what I'm finding is, in discussing with QME doctors throughout the entire state, many doctors are providing for additional permanent impairment due to excess pain, or the added burden of pain, or pain that slightly increases the burden of the examinee's condition. But what's happening is the additional permanent impairment rating is not being upheld. It's not sticking. It's not sticking. And the reason it's not sticking, or there's two reasons that it's not sticking. Number one is that the examinee actually does not qualify for additional permanent impairment under Chapter 18. So that's number one, that they don't actually qualify. So you can provide for the permanent impairment, but if the examinee doesn't actually qualify for it, and if your argument for additional permanent impairment due to pain is not substantial, then it's not going to be upheld. It's simply not going to stick. So that's one reason that the examinee doesn't qualify for it. And then in those cases where the examinee could possibly qualify for additional permanent impairment due to pain, the argument and the process of determining the additional pain-related impairment is simply not compelling. It simply doesn't qualify as substantial medical evidence. And that's really just a fancy way to say that the doctors are doing it wrong. They're doing it wrong. They're not doing their pain-related impairment assessment properly. Many doctors are not doing a pain-related impairment assessment at all, and yet they're providing for an additional 1%, 2%, or even 3% additional impairment due to the added burden of pain without a substantial procedure and without a substantial discussion in the QME report that's compelling and that substantiates the additional permanent impairment. So it's simply not being upheld. So I want to handle those issues with you today. And what you're viewing right now is video number 1 in a 2-part video series. It's going to take 2 videos to adequately discuss all the issues related to the pain-related impairment. And we're going to divide those discussions into 2 videos. So throughout the course of these 2 video series, what I want to discuss with you are the following topics. We're talking about the pain-related impairment, and in today's video, we're going to talk about when and when not to use Chapter 18 to address or to provide for additional permanent impairment due to pain. There's going to be certain very specific circumstances when Chapter 18 will apply, and we can provide for additional permanent impairment due to pain. For the most part, and in the main, Chapter 18 will not apply. And I'm giving you just a little bit of a heads up for when we get there. For the most part, and for most cases, Chapter 18 will not apply. We will not be able to provide for additional permanent impairment due to pain because the examinee simply does not qualify for it. So I'll clarify exactly when and when not we can look at Chapter 18 for additional permanent impairment. And then the subtitle under that heading would then be who qualifies, which particular examinees qualify for pain-related impairment and which examinees do not qualify for pain-related impairment. And I'll give you just a little bit of heads up for when we get to that section. The majority the majority of our examinees are not going to qualify for additional permanent impairment due to pain. And that's what my doctors are finding. They're finding that their arguments for additional permanent impairment are not being upheld. Why are they not being upheld? They're not being upheld because the examinee simply doesn't qualify for it. And I'll explain and elaborate on that fully when we get to that section. And then finally, in video number 2, I want to talk about how to perform a pain-related impairment assessment in a manner that's consistent with the process that's described in Chapter 18 of the AMA Guides. And Chapter 18 requires a very specific process and a very specific procedure for the assessment of pain-related impairment. And I've come across very few doctors who actually follow this process and procedure exactly as it's described in the AMA Guides. So when we get to that portion of this program, we're going to go over completely the pain-related impairment questionnaire that's described in Chapter 18. And I'll review with you exactly how to implement this instrument so that it serves as a tool for you in assessing for pain-related impairment. And we're going to break that form down and we're going to dissect it with a fine-tooth comb, and I'm going to go over many different nuances of that form that will help you arrive ultimately at a conclusion either for or against additional impairment due to pain. And when you make your conclusion, I'm going to provide you with some language that makes your conclusion substantial and basically irrefutable. And I'll take you through an algorithm to arrive at either additional permanent impairment due to pain or no additional permanent impairment due to pain. And when you arrive at either one or the other of those conclusions, the opinion will be substantial, will be irrefutable, and whatever your opinion is, it will be upheld. So I have a fascinating program for you that's going to be of immediate value to you in your QME practice. And so let's get started. We're going to be going through Chapter 18 of the AMA Guides. I'm also going to be making reference to the Master the AMA Guides 5th edition textbook. So if you have those textbooks, I want you to go ahead and get those. We're going to be going over some specific passages, and it's important that you be able to lay your eyes on these passages as we review them, because I want you to actually be with me page for page as we discuss these important references from the AMA Guides. So I'll give you a minute to go ahead and get your books, and I look forward to being back with you in just a couple moments as we review today's topic, which is the pain-related impairments. Okay, I'm back with you now, and hope you have your AMA Guides. I have my AMA Guides with me right here. And then in addition to the AMA Guides, I also have the Master the AMA Guides 5th edition. So this is a companion textbook that goes with our AMA Guides 5th edition. And I'm not sure how many of you have this book, but this is a very valuable reference. And I recommend that if you don't have it, that you do get it, because what this textbook here does is it elaborates on additional concepts and ideas in the actual AMA Guides 5th edition. And it gives many valuable examples and illustrations that are not contained in the AMA Guides. So it's a beautiful companion to the AMA Guides itself. And I'm going to be taking some specific references today out of this book itself as a companion to the AMA Guides 5th edition. So I highly recommend this book if you don't already have it. Okay, so let's begin. We're talking about the pain-related impairment, and in this today's video we're going to be talking about when and when not to use Chapter 18 of the AMA guides, and then we're going to talk about who and who does not qualify for additional impairment due to pain. So before we get into those two topics, I just want to go over a couple of general principles about the pain-related impairment. Now, in our next video, we're going to talk about actually how to do the pain-related impairment assessment. But I want to establish a principle in today's video that from here on out, we're going to do a pain-related impairment assessment on each and every case. So, for example, the pain-related impairment assessment is not something that you decide to do during the qualified medical evaluation as the evaluation unfolds. In other words, you don't make that decision whether to do it or whether not to do it as the interview and evaluation unfolds. Rather, you make the decision that on each and every case you're going to do a pain-related impairment assessment, and then later on when you're back at your office and you're working on the report, you can then decide at that point in time whether or not the examinee qualifies for pain-related impairment or whether or not you are going to even provide for additional permanent impairment due to pain. So we plan on doing a pain-related impairment assessment on each and every case. That way the assessment is done, and that way you have the necessary information should it become necessary or should it become appropriate or applicable to provide for additional permanent impairment due to pain. And it's my opinion and it's my experience that this is not something that can be decided at the evaluation itself, because most times at the evaluation itself you really have no solid and final conclusion as to what the permanent impairment is going to be, what the permanent impairment could be, what your options for permanent impairment under the strict application of the AMA guides or under Alvarez-Guzman is going to be. In other words, the permanent impairment many times does not get solidified in your own head until later on when you're back at your office and you have quiet time and perhaps you've looked at additional new diagnostic studies, and it's at that point in time that the whole conclusion comes together, and it's at that point in time that you don't want to be deciding oh, I wished I'd done a pain-related impairment assessment because this person could qualify for it. No, you want to make sure that you do the pain-related impairment assessment, that you hit all those high notes when you have the opportunity in the face-to-face evaluation with the injured worker, because once you leave that evaluation, it's very difficult to then go back and obtain additional new information should that become necessary. So that's principle number one, and that is we're going to do a pain-related impairment assessment on each and every case. If we then later decide that pain-related impairment does not apply, then we simply don't use that information, but we have it should it become necessary. Okay? So that's principle number one. And then principle number two is it's important to keep in mind that with additional permanent impairment related to pain, the Chapter 18 of the AMA guides is very clear in telling us that the additional impairment related to pain is what's called a discretionary award. What does that mean? What does it mean to provide for a discretionary award? Well, what that means is that we as the examining doctors have the discretion to use our clinical judgment and our experience, and within reasonable medical probability, we can provide at our discretion additional permanent impairment related to pain if, in our opinion, we feel that the examinee is exposed to excess pain or has significant or substantial added burden due to pain. So it's a discretionary award. It's discretionary. It's not mandatory. It's discretionary. We can use our clinical judgment. Well, the principle is that the AMA guides allow us to provide for only one discretionary award. And many of the permanent impairment ratings that are described in the AMA guides, for example in Chapter 15, Chapter 16, and Chapter 17, also allow us some discretion. For example, in Chapter 15, the DRE categories, they allow us to provide for permanent impairment within a range. So for example, DRE Category 2 provides for a range of between 5 and 8% whole person impairment. Well, that's a range, 5 and 8%. That's a 3% whole person impairment range. And we can provide for the highest value within the range. We can provide for 8% whole person impairment under DRE Category 2 if in our discretion we feel that the permanent impairment adversely causes pain or adversely impacts the ability to perform activities of daily living above and beyond what the lower rating would provide for, then we have the discretion of upping the permanent impairment rating to the higher value within the range. And isn't it interesting that there's a 3% range within these DRE categories? Well, similarly in Chapter 16, similarly in Chapter 17, similarly in Chapter 6, and in all of the charts and tables and chapters of the AMA guides, there are situations where we're allowed to provide for a range. I should say in many of the charts and tables, not all of them, but in many of the charts and tables, we have the discretion to be able to provide for permanent impairment within a range. Well, if you provide for added permanent impairment within the range at your discretion, due to your hypothesis as to how the impairment adversely affects activities of daily living, then you've used your one discretionary allowance. The AMA guides would then not allow you to go back and provide for additional discretionary impairment due to the added impact of pain. So in that sense, and this is just a heads up into our first section of today's video, in that sense, that reduces the number of examinees who would qualify for additional impairment due to pain, because that additional impairment due to pain could have already been provided for in your discretionary increase of the permanent impairment due to other charts and tables that allow for a range. Okay? So if you're going to provide for increased impairment due to a range, you can't then go back and apply additional permanent impairment due to the added impact of pain. We're only allowed one additional discretionary award. So that's principle number 2. Okay, so let's begin with our topics today and talk about when and when not to use Chapter 18. And this is going to provide valuable insight to you, and it really will help clarify who qualifies for additional impairment due to pain and who does not. Okay, so let's begin first by talking about those situations where Chapter 18 does not apply. And then we'll talk about those situations where Chapter 18 could possibly apply. Okay, so the first situation where Chapter 18 would not apply is when we're rating individuals who we determine in our clinical judgment who have low credibility. Now, it's interesting because the entire pain-related impairment assessment depends upon the examinee's reports. And it depends largely on the examinee's subjective reports of, number 1, their pain, and number 2, the impact of that pain on their activities of daily living. Now, what's interesting about it is we as the examining doctors have very little opportunity to be able to corroborate the examinee's subjective complaints, and we have very little opportunity to be able to corroborate their descriptions of limitations of activities of daily living. For example, I've never had the opportunity to go to an examinee's bedroom and observe them having difficulty with sleep or having difficulty with sexual relations, as they describe both with their verbal statements and in their responses to symptom questionnaires and activities of daily living check sheets. So we have no opportunity to be able to corroborate the validity or the invalidity or the accuracy of the subjective complaints or the restrictions to activities of daily living. So when you're evaluating an examinee who you feel or who you determine has low credibility, the pain-related impairment assessment is over, because we simply cannot rely on the examinee's subjective statements if, in our opinion, they have no credibility. Okay? So this is where your clinical judgment and your experience and sometimes even your gut feeling come into play. If you have an examinee who is telling you subjective complaints and restrictions to activities of daily living that are out of context with the known medical condition, that are out of context or out of proportion to the mechanism of injury, that are out of proportion and inconsistent with known anatomy. In other words, if you are not comfortable that your examinee is totally credible, then the pain-related impairment assessment is over, and Chapter 18 does not apply. Second situation where Chapter 18 does not apply, and this is fascinating, is when there are ambiguous or controversial pain syndromes. Ambiguous or controversial pain syndromes. So we're talking about providing for additional permanent impairment related to pain. Well, there are pain syndromes that are what the AMA's guides describe as ambiguous or controversial. And the AMA guides cite fibromyalgia and whiplash as ambiguous and controversial pain syndromes. Other pain syndromes that would be ambiguous or controversial would be pain syndromes that don't really correspond to known anatomy. Vague and ill-defined and widespread pain associated with, for example, a cervical spine injury may be described as vague or ambiguous. And this is where your clinical judgment comes into play. And a lot of it has to do, a lot of the decision making as to whether or not the examinee is describing a vague or ambiguous pain syndrome has to do with the diagnosis and your opinion on the permanent impairment. So an accurate diagnosis is important in establishing whether the pain syndrome is a clearly defined pain syndrome or whether it qualifies as something that's vague or ambiguous. And for vague, ambiguous pain syndromes, that Chapter 18 does not apply. And the Master of the AMA Guides 5th edition gives an additional example of an ambiguous pain syndrome. And that would be, for example, the diagnosis of thoracic outlet syndrome. Thoracic outlet syndrome. So imagine an examinee who reports symptoms that would be consistent with thoracic outlet syndrome. In other words, they have upper extremity pain, perhaps some neurogenic claudication. They might have some sensory disturbance such as numbness, tingling, prickling, burning, these other dysesthesias. And they have clinical findings that are consistent with the known condition of thoracic outlet syndrome, and yet the physical examination is negative for all thoracic outlet syndrome findings. So it looks like it could be thoracic outlet syndrome, but the physical exam and diagnostic study findings do not support a diagnosis of thoracic outlet syndrome. This would be an ambiguous pain syndrome. And similarly, the principle is that many times examinees will come to us and they will describe pain syndromes that are not exactly consistent with a known condition. For example, many times examinees come in and describe what sounds to be like cervical radiculopathy, and yet they describe pain distributions unrelated to the dermatomal distributions. For example, an examinee will say, well, it hurts my entire arm. And you inquire and you say, well, what part of the arm? And they say, well, the whole thing. And you say, well, what about the hand? Which parts of your hand are numb? And they say, the whole hand, the whole circumference of the hand. And as we know, that involves multiple nerve roots, and the entire upper extremity could involve as many as 5 cervical spine nerve roots. And yet, based on your physical examination and based on the diagnostic studies, the clinical findings don't support a 5 nerve root radiculopathy. That would qualify as an ambiguous pain syndrome, and in that situation, Chapter 18 would not apply. Okay, finally, Chapter 18 does not apply when pain is adequately related and is adequately rated. I said related. I should have meant rated. So when the pain is adequately rated and is adequately considered in the conventional impairment rating. So additional permanent impairment due to pain is an additional discretionary award above and beyond the conventional impairment rating that you provide for the examinee under a different chapter. For example, for upper extremity cases, we use Chapter 16 to provide for us our different permanent impairment ratings. Well, many of the permanent impairment ratings in these chapters of the AMA guides already consider the impact of pain of the condition. In other words, many of the conditions that the AMA guides provide for permanent impairment are painful conditions. And the pain is already considered, is already subsumed, is already included within the conventional impairment rating. So let me give you an example. We were talking about radiculopathy. Well, if an examinee comes in and they tell you that they have neck pain and that they have pain that radiates down their arm into their hand, and that their hand is numb in the distribution of the C6 nerve root, and they describe prickling and tingling and burning, and we see that they have atrophy of the bicep muscle, atrophy of the forearm muscles, and we see that they have diagnostic study findings that are consistent with a disc bulge at C5, C6. In other words, they have all the clinical findings for radiculopathy. But then the examinee comes to you and elaborates for an hour about the pain in the neck, the pain in the scapula, the pain in the bicep, the pain down in the arm, the pain. At night, the pain keeps me up, I can't sleep. During the day, the pain is, I can't concentrate. I have pain, I have to shake out my hand. I grab stuff and I drop objects. Feels like there's a knife pick through my hand when I type. The pain, 1,000 examples of pain. What is the doctor's conclusion? What is your conclusion in this situation? Your conclusion is, I know. Radiculopathy causes pain. the permanent impairment rating that the AMA guides provide for radiculopathy includes the pain, includes the neck pain, includes the scapula pain, includes the pain down the arm. The pain is already considered in the permanent impairment rating. So if in your opinion the pain that the examinee describes is consistent with the condition, then there's no additional permanent impairment due to pain, because the pain is already included within the conventional impairment rating. And I have an interesting scenario to analogize to this, and this is something that you've probably experienced before yourself in your career as a qualified medical evaluator. Have you ever had a circumstance where you provide an evaluation for an examinee and you provide for a permanent impairment rating, and let's just make one up. Let's just say it's a lumbar spine case and you provide for, I don't know, 13% whole person impairment. And then about a year or two later, the examinee comes back for a reevaluation for whatever reason. You know, you thought they were permanent and stationary, but now they're coming back for whatever reason. Have you had those cases? I've had those cases all the time. Well, when the examinee comes back 2 years later and they tell you about what it's been like for the past 2 years since you provided them their permanent impairment rating, and they'll say things like, oh, the pain, you know, the pain is terrible and I can't do stuff, and this pain is not going away, and this pain is always there, and this pain is ruining my life. What's the reasonable conclusion? What do you conclude as a qualified medical evaluator? You can conclude that you already knew that. You already knew that. You knew they were going to have pain. You knew they were going to have a miserable life. You provided for permanent impairment. Permanent. The permanent impairment is permanent. You provided for a permanent impairment rating of 13%, which represents a significant loss of use or loss of function of the organ or organ system. Of course they're going to have pain. Of course 2 years later it's going to be miserable. It's a permanent impairment rating. So in that situation, the pain and the misery and the suffering is already included in the permanent impairment rating. You can predict that your examinees are going to experience pain. Pain is part of the permanent impairment rating. Okay? I think I made that point clear. Okay? So Chapter 18 does not apply when we have examinees of low credibility, when there are vague or ambiguous or controversial pain syndromes, or the pain is not associated with positive objective findings for a known medical condition, or number 3, when the pain is adequately considered and included within the conventional impairment rating, then there's no additional permanent impairment rating due to pain. Okay, well, what about the other side of the coin then? What are the instances wherein we can use Chapter 18 to provide for additional permanent impairment related to pain? Okay, so let's talk about those situations. Well, one of the situations that the AMA guides elaborate on thoroughly is when there are well-established pain syndromes. Well-established pain syndromes. Now, we said that we could not use the AMA guides when we had pain syndromes that were ambiguous or controversial. What's the opposite of ambiguous or controversial? How about well-established? Well-established. So when we have well-established pain syndromes, then the AMA guides do provide for additional permanent impairment due to pain. Specifically when those well-established pain syndromes are not associated with any identifiable organ system dysfunction that provides for a permanent impairment rating in any of the other chapters of the AMA guides. And the best example of a well-established pain syndrome that the AMA guides discuss is, for example, headaches. Headaches. Now, most headaches by physical examination have no positive objective findings. I say most headaches. Of course, there are exceptions to this. You know, if you fall down some stairs and hit your head and have a headache, of course there would be positive objective findings for that. But for the most part, headaches have no positive objective findings. So there's no identifiable organ system dysfunction for which we can provide permanent impairment rating. So in those situations where we're not able to identify the specific organ system dysfunction, in other words, there are no positive objective findings, but we have a well-established pain syndrome, then Chapter 18 does apply. Now, let's elaborate further on headaches. As we know, there are many different causes of headaches, and some of the causes of headaches do have identifiable organ system dysfunction. For example, if you have an examinee who suffers an injury to the cervical spine, perhaps from a whiplash, perhaps from a slip and fall injury, perhaps from degenerative disc disease, those conditions can cause headaches, and we refer to those as cervicogenic headaches, headaches that arise from the cervical spine. Well, in this example, the cervical spine examination and the cervical spine diagnostic studies would be significant for organ system dysfunction of the cervical spine. In that case, the headaches and the pain associated with the headaches are subsumed and included in the permanent impairment rating due to the cervical spine. Whatever you decide the cervical spine impairment is, it includes the pain associated with the headaches. So that's an example where headaches and the pain associated with headaches would be subsumed in the conventional impairment rating for another condition. But with many headaches, there are, for example, migraine headaches, there is no identifiable organ system dysfunction that provides for permanent impairment to explain the headache pain. In that case, Chapter 18 can provide for permanent impairment due to the headache pain. So headaches in that sense qualify as what the AMA guides describe as a well-established pain syndrome. And there are other well-established pain syndromes as well. And let's refer here to Table 18.1 of the AMA guides. Table 18.1. Okay, so let's go to Table 18.1. So here's a list of well-established pain syndromes. And this is not an inclusive list, but this is some examples given to us on page 571 of the AMA guides. So most headaches, we talked about that. Post-herpetic neuralgia. So the examinee comes in and says, I had shingles. I had shingles. A month ago I had shingles. And now I have this pain around my thorax, pain in my ribs, burning pain. And you as the evaluator take a look and you do a physical examination of the thorax, and you see that the herpetic lesions are healed. There's no significant positive objective findings. Sensation along the distribution of the intercostal nerves is normal. Function of the motor portion of the thoracic spine nerve roots, meaning the abdominal muscles, are strong and are functioning properly and have +5 muscle strength. And there's no significant positive objective findings, but the examinee describes pain that's consistent with the well-established pain syndrome that we refer to as post-herpetic neuralgia. That could qualify for additional permanent impairment because there are no discussions of post-herpetic neuralgia in other sections of the AMA guides. I believe Chapter 13 describes post-herpetic neuralgia of the cranial nerve, but does not describe of cranial nerve number 5. That's discussed in Chapter 13, but post-herpetic neuralgia of any of the other cranial or spinal nerves is not. And so that would be a situation where Chapter 18 would apply. Other conditions, trigeminal neuralgia known as tic douloureux, erythromelalgia, which is a peripheral neurovascular pain syndrome. That's an example. Basically, any injury to the nervous system that causes pain that's not described in other chapters of the AMA guides could qualify for pain-related impairment. Okay? And this is not an exhaustive list. You may know other examples as well. Okay? So those are known as well-established pain syndromes, and those are the opposite of the vague and ambiguous and controversial pain syndromes. Okay, number 2 opportunity for us to use Chapter 18 is when there are other associated pain syndromes associated with conditions that are rateable according to the conventional impairment rating system. So let's clarify this a little bit. We have an examinee who has a permanent impairment due to some organ system dysfunction in one or more of the chapters of the AMA guides. Well, some of the permanent impairment ratings that the AMA guides provide for are not associated with pain. They're simply associated with loss of parts or loss of organs or organ systems. And the examples that the AMA guides provide to clarify this concept is an examinee who has an arm amputation. Now, we know that examinees with arm amputations can have pain in the amputated portion of the extremity, and we know examinees can be blessed and not be plagued by pain below the amputation. Now, when the examinee has pain, we refer to that as phantom pain. And the AMA Guide's permanent impairment rating for amputation simply considers the fact that the body part is then removed and the examinee no longer has the use of the body part. It doesn't consider the added impact of the pain. So we refer to phantom limb pain as an associated pain syndrome. It's pain that's associated with an impairment, but the impairment in the AMA guides does not consider the fact that the examinee could have pain. And the AMA guides give us a list of associated pain syndromes in table 18.2. Okay, so let's describe some of the associated pain syndromes. Associated pain syndromes include, for example, post-paraplegic pain. Post-paraplegic pain. Not everyone who's a paraplegic has pain. They're paraplegic, they're paralyzed, they have loss of motor function, but not all of them have pain. And so those that have pain could qualify for pain-related impairment due to an associated pain syndrome. The pain is associated with the condition of paraplegia. Syringomyelia pain. Some examinees have a syrinx in their spinal canal, a cyst, a fluid-filled cyst that occupies space within the spinal cord. And that can cause a variety of symptoms, both sensory and motor. And not all examinees experience pain. But if you have an examinee who describes pain associated with syringomyelia, the pain is associated with the condition, and they could qualify for additional impairment due to pain. Brachial plexus avulsion pain, nerve entrapment syndromes, peripheral neuropathy, thalamic syndrome. Some examinees who have a thalamic stroke, also known as post-thalamic syndrome, typically will initially experience a variety of different dysesthesias, strange distributions of numbness and tingling and loss of light touch sensation, these various dysesthesias. And then later on, after months and years, some of these examinees will report the onset of severe pain associated with thalamic stroke. Well, a certain percentage of thalamic stroke patients do not describe pain, but some do, and the pain is associated with the condition. So it's what the AMA guides refer to as an associated pain syndrome. And they describe many, and this is not an exhaustive list, but it gives us some examples of different types of conditions that in some examinees can cause pain, and in some examinees cannot cause pain. And when you have an examinee that is suffering with the added burden of the pain, then Chapter 18 does provide for additional permanent impairment for those individuals. And what we mean by this, and just to elaborate further, is that the conventional impairment rating that's provided for these conditions, for example, the amputation, the conventional impairment rating for amputation does not capture the added burden of illness borne by individuals who have the associated pain syndrome compared to other individuals who also have amputation but who do not have pain. And so in that situation we could use Chapter 18. And then finally, who else could qualify for additional impairment due to pain, and when else can we use Chapter 18? Well, Chapter 18 can finally be used for those examinees who describe for us what the AMA guides refer to as excess pain. Excess pain. Excess pain in the context of a verifiable medical condition that's known to cause pain. It's already known to cause pain, but in our opinion, as an evaluator, they have excess pain. They have added burden of illness due to pain. Now, this is where if you provide for permanent impairment due to your examinee due to excess pain, and you provide for an additional 1%, 2%, 3% whole person impairment due to the added burden of the pain, your description and your argument for the additional permanent impairment has to be good, has to be compelling, it has to be substantial, it has to qualify as substantial medical evidence, and you must thoroughly and adequately and in a compelling fashion explain how and why you believe that the examinee is suffering from excess pain. Excess pain. Because, as we said earlier, most of the conventional impairment ratings that the AMA guides provide for consider and include the pain. So let me give you an example of this. In Chapter 1, page 10 of the AMA guides, it says, this is a second column, it says here that physicians recognize the local and distant pain that commonly accompanies many disorders. Impairment ratings in the guides already have accounted for commonly associated pain, including that which may be experienced in areas distant to the specific site of pathology. And they give an example. They say, for example, when a cervical spine disorder produces radiating pain down the arm pain, which is commonly seen, has been accounted for in the cervical spine impairment rating. Has been accounted for in the cervical spine impairment rating. So most of the permanent impairment ratings within the AMA guides already consider the pain. Okay? And I love radiculopathy because it's a great example. Not only does the permanent impairment rating for radiculopathy consider the pain, it considers all of the sensory phenomena associated with compression of sensory fibers. Correct? So it includes the numbness. It includes the tingling. It includes the aching. It includes the pain. It includes the loss of light touch. It includes the loss of vibration. It includes the loss of pressure. It includes the loss of cold and temperature discrimination. It involves the loss of two-point discrimination. All of the sensory phenomena, including pain, are subsumed in the permanent impairment rating for radiculopathy. Well, similarly, all of the motor functions of the cervical spine nerve roots and the motor fibers are included in the impairment rating for radiculopathy. So let me ask you, if you have an examinee who has, say, C5 radiculopathy, and you do your physical examination, and you find that indeed to manual muscle testing of the supraspinatus and the deltoid muscle, you find that they're weak, do they qualify for additional permanent impairment due to weakness? They don't. They don't. Because the loss of motor function is included in the permanent impairment rating for radiculopathy. Okay? So what if the examinee presents to you, and on inspection of the examinee, you inspect them and you see that on the side of radiculopathy, the deltoid and the upper bicep muscle has atrophy compared to the contralateral uninvolved side. And there's wasting and inhibition and disuse atrophy and pain-related inhibition of those muscles. Do they qualify for additional permanent impairment due to atrophy? They don't. Because the permanent impairment rating for radiculopathy includes all of the losses of function of the motor fibers. What if they have atrophy of the cervical paraspinal muscles that are innervated by the dorsal primary rami of C5? Do they qualify for additional permanent impairment? No. We would expect that they would have atrophy of those muscles. In a bona fide case of radiculopathy, they're going to have atrophy either due to denervation atrophy or disuse atrophy or pain inhibition atrophy. If they're protecting their cervical spine and not moving it because it's painful, then that atrophy is subsumed and included in the permanent impairment rating for radiculopathy. So the AMA guides already include the pain. Now, we as doctors and evaluators have the discretion to provide for additional permanent impairment if, in your clinical opinion, the examinee is suffering from what you consider to be excess pain, pain above and beyond that which you would expect given the diagnosis and given the permanent impairment rating. So let me give you something to think about. And this is a quote that comes from the Master of the AMA Guides 5th edition textbook. It says that the analysis of whether or not to award additional pain-related impairment varies depending on the relationship that the examiner, that's us, hypothesizes between the individual's pain and a well-established medical condition. It varies based upon the relationship that we hypothesize between the condition on one hand and the pain, symptoms, and activities of daily living restrictions that the examinee reports on the other hand. So when examinee describes their condition, we have in our mind some sort of a mental construct based upon our experience of how those symptoms could be distributed and how those symptoms could impact activities of daily living. So to use the radiculopathy example, when an examinee comes in and they describe having radiculopathy, they don't tell us they have radiculopathy, but they tell us that their whole syndrome is consistent with what we describe as radiculopathy. What you want to do is you want to ask yourself the question, okay, how would I expect radiculopathy to present? Am I surprised that there's pain? No. Am I surprised that there's sensory disturbances? Should you be surprised? No. Should you be surprised that there's motor losses? No. In other words, how do you hypothesize the relationship between the symptoms and the known medical condition? We should not be surprised when the examinee describes painful suffering with a well-established condition that causes pain. Now, if you believe that the examinee credibly and reliably reports excess pain, and I really don't have any way to describe for you what would qualify in your opinion as excess pain, but you do have the discretion to provide for permanent impairment for excess pain if you determine that such exists. When you determine that, you can provide for additional permanent impairment under Chapter 18. And as I said, your description and your argument for additional permanent impairment in these situations has to be compelling and has to qualify as substantial medical evidence. That is, if you want it to be upheld and you want it to stick. Okay, and so what's going to happen is basically when you have an examinee who presents to you with subjective complaints of pain, that pain is going to be resolved in one of three manners. Number one, the pain is going to be unrateable. And it'll be unrateable if you determine that there's a vague, ambiguous, or controversial pain syndrome, or if you determine that the examinee has low credibility, or if you consider that the pain is not consistent with known anatomy, or there's a controversial pain syndrome. In those situations, the pain is simply not rateable and Chapter 18 does not apply. Number two is that the pain that the examinee describes is already going to be accounted for in the conventional impairment rating. And so there will be no additional pain-related impairment because the pain is already adequately considered in the permanent impairment rating that you provide, especially if you provide for added discretionary permanent impairment within a range of ratings provided for in other chapters of the AMA guides. And then finally, in those rare situations where you have a well-established pain syndrome without identifiable organ system or dysfunction, that could qualify for additional permanent impairment due to pain. Or if you have an examinee who has a bona fide condition and has a pain associated with it, whereas other examinees have the same condition but do not have the pain, then we can provide for additional permanent impairment